This is a lecture about Chapter 2, Health Insurance, in our revenue book. We're going to be learning about different types of health insurance as well as managed care organizations. On your Module 1 test, there will be 20 questions from Chapter 2 for a total of 36 questions on the Module 1 unit exam. Okay, let's get started. There's your objectives for the chapter. Now, there are 3 ways that we can get insurance. 2 of those are listed here. Individual, which is where we can go and purchase it from an insurance agency. Second way is employer-based, which is where you get it as part of an employment benefit package. And then the third way is government-sponsored, which would be Medicare, Medicaid, and you're going to learn about that in our next module with Chapter 3. The types of health insurance, we have single coverage, and then we also have family coverage. With single coverage, you only insure the policyholder, so it's only one person. With family coverage, you insure the beneficiary or that insured person, plus their spouse, children, young adults, and disabled person. Now, this is usually can be bought at an insurance company or employee-based. As far as the children, it is natural as well as adopted, and that's usually up to age 26. Family coverage usually costs more. It's important that you know who can be covered with family coverage. With the disabled people, that does that has certain requirements that are covered with those, and that would be listed in your insurance policy. Now, we talked a little bit in Chapter 1 about a risk pool. Remember that risk pool helps to determine the cost of the insurance, but you do need to know the definition. It is a group of individual entities whose health care costs are combined for evaluating financial history and estimating future cost. So it's important that you know this definition right here. Remember that risk is the probability of incurring a loss. The risk pool can combine individuals, employers, and associations. The larger the group, the lower the cost. Smaller pools may have a higher cost because of that adverse selection or that large selection of those with poor health. Now, the greatest advantage of that group health is that there's a greater benefits of a lower premium. So that larger group usually has a lower premium because of the more diverse risk pool. Now, here's some terminology that we use whenever we're discussing health insurance. The first one there in blue is our benefits, also known as our covered services. This is the healthcare services for which the insurance company will pay as outlined in the policy or the contract. Our premiums, and we talked about that in Chapter 1. Remember that is payments that the policyholder must make to the insurer in return for health care coverage. In green, we have the policyholder. That's the individual or entity that purchased the health insurance plan. Alternate terms can include the insured, certificate holder, member, subscriber, and beneficiary. Cost sharing provisions, those are our out-of-pocket expenses. You see there we have the deductible, which is an annual amount of money that the policyholder must pay before the insurance will assume its share of the liability. It a lot of times is higher for an individual. Employment-based insurance usually has a lower premium, deductible, and cost sharing, usually has greater benefits than individual plans. Because remember, we discussed in chapter 1, the employer and the employee a lot of times share the cost of that insurance. Now, another term that goes along with our insurance is a policy. This is a formal contract between the insurance company and the individual or group for whom the company is assuming risk. Sometimes it's also called the certificate of insurance, which just simply describes the conditions of the policy. In this policy, it's going to stipulate what conditions are covered, the conditions, illnesses, diseases, symptoms for which the insurance company will reimburse for treatment. It attempts to maintain, control, or cure. It's also going to indicate services that maybe aren't covered, maximum amounts that will be paid, what the patient's responsible for. It also contains the summary of benefits and coverage, which is called the SBC. This is the document that in plain language concisely details information about the benefits and its coverage of health services. It's presented in simple, consistent, and uniform format. This is a summary for the patient, and it doesn't replace anything else. It's just that, a summary. Now, these are some sections that we're going to see in an insurance policy. Each section builds on another, and you may see where there may be some overlap of the information. So what you see in one may be seen in another. The first one is definitions, and these are definitions that they vary from what you would find in an everyday dictionary. They may be more restrictive or more related to the actual policy. They impact what will be covered and reimbursed. So a lot of times the definitions that we get may be emergency, a prudent layperson standard, prior authorization, what is considered life-threatening, an accident, medical necessity. All of those would be definitions we may find. The next section is eligibility and enrollment. Eligibility is who's eligible, so it would tell us what is considered a dependent, who can apply. It can tell us the waiting period. Sometimes it may be an immediate entry, sometimes you may have to wait. It does specify in most cases that you can't be required to wait more than 90 days for insurance. Guaranteed issue for ACA, remember that's the Affordable Care Act. They do have to accept all that apply if somebody's going into the portal to get insurance. Now, there are specific employments. We have qualifying life events, QLEs, and you have to know what is considered a qualifying life event, and that is loss of your insurance coverage, marriage, divorce, birth, and adoption. And with these, you have 30 days to request enrollment, and there is immediate enrollment. You do not have to wait. There is no waiting period when you have one of these qualifying life events. So if you were to get married and you wanted to get insurance with your spouse, that would be immediate. You just have to show the proof, the documentation that they ask for. With enrollment, you do have to follow the insurance's policies and procedures to apply. Now, when it comes to enrolling, a lot of insurance companies have an open enrollment, which is 2 times within 30 days of when you are hired for a job. And then they also have an open enrollment that is usually 1 time a year during an open enrollment period. Sometimes it's in the fall. And that enrollment is for the next coverage period, which is usually for the next year or next 12 months. When you are in either open enrollment or just being hired, there is no waiting period. During this time, you can make changes. You can change your insurance company. You can change your coverage. There's no penalties whenever you do that during those open enrollment periods. The next section is your benefits. This specifies what's covered, what's reimbursed, specifies the services, types of providers, types of medical equipment. It's going to tell us our maximum out of pocket, that's the amount of money, and the time period for when items are going to be paid. It talks about our catastrophic expense limit, benefits at different levels. Now, page 23 in your book, it does give us some services that are covered. Talks about the healthcare services that can be provided by physicians, health practitioners, visiting nurses, and preventative services, acute care, inpatient, outpatient, emergency department, vision, dental, labs, x-rays, rental of DME, that's durable medical, prescription drugs, rehab, emergency transport. All of that are types of services, and in your policy it will spell out exactly what is covered as your benefits. Something's not covered as a benefit, then that means that the insurance company is not going to pay for it. Now, you're also going to see there with a little star, essential health benefits. There are 10 categories that are required by the ACA. That is listed at the bottom of 23 and 24. So you have ambulatory patient services, outpatient care, prescription drugs, emergency care, behavioral health services, hospitalization, rehab and habilitative services, preventative and wellness services, lab services, pediatric care, maternity, and then newborn care. Now, a couple of other terms that you see in this section. Deductible, again, remember that must be met before the insurance. We have something called cost sharing in this areas. That's our co-insurance and co-payments. They must be paid until you reach your maximum out-of-pocket. Your co-insurance is a pre-established percentage of the expense after your deductible is met. And then you have your copay, which is a fixed amount per service. There is on page 24 a list of limited benefits that must be paid, and they can be paid at different amounts based on different policies that you may have. You may have supplemental insurance policies, which are kind of fill-ins that may cover items that your benefit section may not pay for. For example, there's a long-term care policy that you can pay for because your regular health insurance won't pay for a long-term care. Accident, disability. As a member, you purchase plans that are based on your health needs and your financial stability. Now, I tell students all the time that you need to understand your policy and you need to understand what you're paying for and what you have. And during your enrollment period, you need to pick what suits you and your family the best. Now, our next slide talks about our limits. Our limits is what qualifications that limit the extent of the benefit. And so one thing that falls under this is cost sharing. And there's some cost sharing items that are listed here. You have co-insurance, co-payment, and tiered benefits. Now, under co-insurance, again, that's that pre-established percentage of eligible expenses after the deductible has been made. That says see figure 2.3. That should actually see 2.2. And it gives you an example of how to calculate co-insurance. So if your co-insurance is 20%, then you would multiply 20% times that reimbursement to know how much you would have to pay. Co-payment, that's that fixed dollar amount. That's where every time you go, you have to pay so much per visit. Remember, with co-insurance and co-payment, you pay that until you have met your maximum out-of-pocket. Once you meet your maximum out-of-pocket, then you won't have to pay anything. Tiered benefits, those are usually seen with your drugs. Those are levels of coverage, and it's based on the insurance that you have. It can also be based on in-network versus out-of-network. And this is like a pharmacy formulary where the certain drugs are allowed that they will pay for and certain drugs are not. Another thing that's under limits can be prior authorization or pre-approval that you must get before services are provided. We're going to talk more about that as we go through this lecture. But remember, limits, copay, coinsurance, prior authorization, they limit what the insurance pays, and it kind of puts more on the patient to have to pay. In your book, it talks about something called moral hazard. And what it says is it decreases that moral hazard so that the patients take it more serious if they have to put something forward and they have to pay something. And there's that figure 2 again. We're going to do at the end, we're going to look at some of the tables. So exclusions. Exclusion is a situation when a treatment is not covered. So you need to know these. These are things that aren't covered. Experimental or investigational devices, not covered. If it's medically unnecessary, it's not covered. Cosmetic, unless it's got some things in the policy, like for example, sometimes if it's related to an accident or congenital defect, that's not paid for. And then anything that is not approved by the FDA, not paid for. So make sure you know what an exclusion is and what things are excluded. Here's a little bit more about that prior approval. So again, remember that prior approval, also known as prior authorization or pre-certification. Certain services require that prior approval in order for the service to be covered. Failure to get that approval will result in the service being denied. Now, the other thing is that not only will it be denied, if you have that, it would result in the patient having to pay for it themselves. So there are some examples: physical therapy, organ transplant, private nursing. Also, though, outpatient surgery, outpatient procedures, behavioral health, substance abuse, inpatient care, occupational treatment, speech therapy. All of those things require prior approval. So you need to know what is prior approval and the items that do require it. Coordination of benefits and then other party liability. These are when we have more than one insurance and you have to figure out who is responsible. So coordination of benefits is when there's two insurances, and it's plain and simple, just there to make sure that we don't end up paying more than 100% on an event. So it helps to designate a primary and a secondary insurance. So your primary takes responsibility or takes precedence over your spouse's insurance. For children, they have what's called the birthday rule. The birthday rule is whichever parent has their birthday the first will become primary and the other will become secondary. OPL, other party, is when somebody else is responsible for that bill. And this would be a case of an automobile. Maybe you were in a car wreck, so the car insurance is going to pay the bill rather than your own health insurance paying the bill. Next is managed care. So in the 70s, they started these HMOs, health maintenance organizations, that were managed care. They were a way of combining services and delivery into a managed care type format. In 1973, we had the HMO Act of 1973 that gave grants and loans for these new HMOs. They have evolved into numerous types of plans, HMOs, PPOs, POS, but their goal is to provide affordable, high-quality health care, and they attempt to manage care by integrating 3 items there that you can see in that funnel. We have clinical, administrative, and financial, and they do that and try to manage the access, cost, quality of health care. So with this, what happens is that they have primary care physicians who are responsible for a beneficiary or a patient, and that person is the one that will then manage the care of that patient. And if the patient needs to go somewhere else, then they can refer them to other physicians. They act as a gatekeeper who decides what that patient needs to go do and see. They send them to specialty physicians if they need to do that. They are very much preventative care and wellness. They are trying to prevent chronic disease from occurring so that way, hopefully down the road, the patient will be in a better state of health as they age. On the bottom of page 29, the top of page 30, are some benefits for the HMOs and managed care that you can go in and look at. And then we have 2 different characteristics that we're going to look at. This is table 2.1 that's on page 30. Now again, remember we're using that primary care practitioner or PCP as the gatekeeper. That can be a doctor, a nurse practitioner, the PA. They are the primary contact for that patient, and their job is to provide high quality of care. So we do that in 4 ways. The first is the selection of the provider. They have standards and procedures in place. They look at quality, senior clinical, credentialing, and periodic re-credentialing of these providers. They look at their scope of service and their location. Number 2, the health of the population. So they're looking at healthcare services across the continuum of care, the different settings, the type. Preventative care, they use something known as evidence-based clinical practice guidelines, where they look at guidelines for treatment. Health and wellness management, they're looking at smoking and drinking cessation. Are you staying healthy? Are you exercising? Are you eating like you should? Number 3 is the care management. This is coordinated by your primary care. And then they're using that disease management. Again, they're looking at that evidence-based, and they use practice guidelines to make sure that they're following up on your disease management. I'm going to use diabetes as an example. Are you monitoring your blood sugars? Are you exercising? Are you seeing a dietitian, nutritionist for your diabetes, for your diet? Or are you seeing a podiatrist to have your feet checked to make sure that you're not having a potential other complication? So they're having this disease management where they're looking at all the aspects of that disease. They may be referring you to a specialty care center that can help you with better control of that disease. Number 4 is the quality assessment and improvement. So they're looking at those accreditations for their facilities. They're also looking at performance improvement. They do a lot of surveys of their beneficiaries, trying to get feedback. What needs to change? What can they make better? Are there suggestions? What are the perceptions of those members? Next, and this is table 2.2 on page 31, this is the cost-effective side, or the cost controlling. And we look at all 3 of these to try to control the cost. So remember, the first ones that we were looking at were, how do we provide high-quality care? This is how do we control the cost with managed care. So we're kind of looking at all three of these. First of all, that service management. We're looking at medical necessity and utilization management. Now, utilization management is where we look at the facility. Are they efficient? Can they provide the care you need? Is this the most effective place for you to go? They're doing site of service. Utilization review. Is this the most appropriate place for you to be? We still have the gatekeeper. We have the prior approval. They may send you for second or third opinions. We have case management, where we have these case managers who are coordinating these complex cases. We have prescription management. Under reimbursement, we have these prospective reimbursement methodologies. We're bundling. You have one cost for an entire episode. Financial incentives can be positive or negative. Positive may be bonuses. Negatives may be where we're taking money away. But we have to combine all three of those. So again, when we're looking at cost, service management, reimbursement, and finances. Now let me give you an example of that bundled payment for pregnancy. When you go in, let's say you find out you're pregnant, from that moment until delivery is one bundled cost. It pays for, depending on your insurance, it pays for a certain number of prenatal visits, and then it will pay until you have your, sometimes it's 6 months, 3 months, sometimes it's 2 months, post-delivery visit, but all of that is one cost. So that whole time that you're being treated, as long as you have what they call a normal delivery, there's one cost that will be included in that bundled payment. You remember that from coding, any of those bundled codes, that would fall under that reimbursement where they're bundling those codes together. All right, so let's go back and review. Case management tools. Primary care, they have the gatekeeper. They refer you to a specialist. Disease management, that's just where they're trying to prevent those chronic diseases. Now, they have listed there congestive heart failure, CAD, which is chronic arteriosclerotic disease, can't talk, asthma. They're trying to improve your health, quality of life, decrease hospitals and admissions. We have that evidence-based, where they're following those clinical decisions, those guidelines, that standardized treatment of care. Next, we have a review of medical necessity and utilization review. Remember that medical necessity is that healthcare services and supplies that are proved or acknowledged to be effective in the diagnosis, treatment, cure, or relief of a health condition, illness, injury, disease, or its symptoms, and they're consistent with the community's accepted standard of care. Only services, procedures, patient care that are warranted. Utilization management, program that evaluates the healthcare facility's efficiency in providing necessary care. This prevents overutilization or unnecessary consumption of healthcare services. Now, if you ever see a medical necessity, Medicare has 4 areas that they require for medical necessity, and they're all real similar, and they're very much like that blue box. So make sure you know about the Medicare side of medical necessity. Remember, with utilization review, we have 3 parts. These 3 parts can be found in Table 2.3 on page 34. You have the initial clinical review, the peer review, clinical review, and then you can appeal. You need to know those 3 parts. That's how they do utilization review. There again, the gatekeeper, whether referrals are warranted, that'd be a medical specialist, a site, a hospital. They do that prior authorization. The policy delineates which healthcare services are going to require that. Remember, that's going to be in our policy, usually under benefits. Second and third opinions, that prevents unnecessary tests. We have that case management. That is going to help with the complex cases. That's usually, these people are going to have a case manager. Workers' comp, severe head injury. We have prescriptions where we have a formulary. A formulary is a list of medicines that the insurance company will pay for or will not pay for. We can have pharmacy benefit managers. They administer health plans prescription drug benefit. We have the prospective reimbursement where the plans share the risk of the cost. So if you had to summarize how do they control costs, it would be with selecting the providers carefully, medical necessity, utilization review, gatekeepers, PCP, case, and prescription management. It would be everything off of this slide and the slide before. That's how they would control their cost. Now, this last slide is their financial incentive review. Providers can get referrals, inpatients, productivity, the number of visits per day. It can be positive with bonus. It can be negative when stuff is taken away. Members, they have cost sharing. High co-insurance if they go out of network, so it's a plus for them to stay in network. It is higher co-payment for them to go to the emergency room visit versus going to an urgent care. So it's better for them to go to an urgent care. I think with my insurance, if I go to the urgent care, I think it's $35. And if I go to the emergency room, I think I have to pay $250. And that's before I ever get seen. That doesn't include anything that I might have to be seen. So those are incentives. So my financial incentives could be like the medical necessity and the disease management, those types of things. Now, with our types of MCOs, our managed care, so we kind of has progressed to these different types. With that, we've had a continuum of control. We've gone from very strict to the least controlled. Our HMO, our health maintenance organization, they are the most controlled, whereas our PPOs listed here have the least control. The HMO has a variation of freedom. They have different models. Our PPO is more flexible. They have greater freedom. We have something called POS, or point of service. Our point of service, when you get there and you need service, at that point you can decide, do you want to go HMO or PPO? The payments increase if you are out of network. And if you are point of service, then you don't make a decision during open enrollment. The other two, you do make a decision. Okay, this goes along with our little patient at the end of our chapter. So, we have Olivia. This starts on page 38. So, Olivia's health insurance premium is $2,000 per month. Wow, that's high. Her portion of the premium is 30%. So, she pays $600. So that means that she pays $600 and her employer pays the difference. So what is that, $1,400? Let me get my calculator. Don't want to be ciphering wrong. So 2,000 minus 600. It's 1,400. So her employer pays 1,400. Her plan has a $500 deductible for the family. In January, her husband had the flu and sought treatment, which totaled $430. So he has already paid, the husband paid $430. So out of the $500 deductible for the family. So that means that what do they have left for a deductible? It looks like they have $70 left for a deductible. Does everybody see how I got that? If they had $500 deductible and he spent $430, 500 minus 430 leaves 70. All right, so this is her cost sharing limits. So if you go to a doctor, primary care, it's $35 in network, and then it's 20% co-insurance for other outpatient provided during. Deductible does not apply. A specialist is $50, and then if you do preventative, there's no charge. These are out of network. Ooh. If I have a test, it's $15. If I have, so remember that I'm going to pay these copays until I reach what? The maximum out of pocket. I'm going to have to make those copays. Copay, I have to pay. Co-insurance a lot of times relates to my deductible. For this one, it says that the deductible does not apply. So Olivia is 5 months pregnant. Following is a summary of Elizabeth's health care for the past 3 months. So on March the 15th, she paid OB visit. She paid $70 for her deductible and $50 her premium, and then she paid $50 copay. She went to the primary care. She paid $35 copay. She paid her premium $60. She paid her copay of $50, and she paid her premium of $600. Now they include your premium in here, but your premium really isn't going toward your insurance cost as far as your yearly bill, as far as what you're going to pay. So here again, she paid $50. So now I want us to go back. So it says that on March the 15th, she paid $50. She had her first prenatal. She paid the remaining $70 of her deductible plus the co-payment for her first visit, which her plan considers specialty. So she paid copay $50, and then she paid that every month. She paid that. On April the 25th, she saw her PCP for seasonal allergies. And I'm reading this on page 39 in your book. So when she saw her PCP, her primary care to treat an injury or illness, how much did she pay for a copay? She paid $35 to her PCP, and her PCP prescribed eye drops. Now, the eye drops are tiered, 1, 2, 3. So on April the 25th, she paid $10 for a prescription. So what tier were they? They were a generic tier 1. So that was how much she paid for her drops. And then every month she's still paying. So that's our chapter 1. Now let's look at a couple of chapter couple of others in here that I wanted us to look at. So chapter 2, cost sharing. All right, make sure you know these definitions: co-insurance, co-payment, cost sharing, deductible, tier. Here are these again with some examples. Make sure you know those. Here again, it's telling us to look in your book. That figure 2.1 is on page 26. It's telling us to look at that cost sharing. Co-payment amount for a primary care visit is $35. Tier 1, surgery. Examine that. This is what we just looked at the end of the chapter. And that's what we just went through. Okay, so that's that one. Now, let's look at chapter 12. This is another one. Again, formulary, gatekeeper, medically necessary, PBM, primary care, pre-authorization, utilization management. Make sure you know these terms. All of these are the service management tools. Make sure you know them. Make sure you know what they are. Cost containment measures, utilization management, site of service. Make sure you know these terms. A lot of this chapter is terms. Here's those 3 steps in the utilization review. First one, second one, and then the third one. That was in your book. That's on page 34. There again, it talks a lot about the gatekeeper, the primary care, and him getting you referrals to the places that you may need assistance. Prior authorization, get that prior authorization before anything is needed. That's going to be the doctor's office's job. So if you go to work in a doctor's office or even in the hospital, that may be part of what you're doing as your job to make sure that the facility receives payment. This is about the second and third. There's that case manager. Remember that case managers, they coordinate that care. Here's some examples. Workers' comp needs a case manager. Those complex cases, they need case managers. That's about the prescriptions. And then one last thing I want to show you in this is an article. And in here, it gives you an introduction and it shows you about insurance. Shows you how insurance was with COVID and about a little bit about different states. But it does a great job of showing you copays, about deductibles, what is a premium, and y'all, that's stuff that you need to understand as far as your own insurance. You should be able to look at your insurance card and you should be able to say, hey, when I look at my insurance card, this is how much I'm going to pay for this, this, and this. And most of the time it's on your insurance card. You should be able to look at it and say, hey, this is what I'm going to be able to, this is what I'm paying. So now one last thing I want to do. Oh, I don't want to look at a Medicare card. Let's do an image of an insurance card. Let's do an insurance card that is not. Okay, let's look at this insurance card right here. So if I look at this insurance card, it's going to have a name, an ID. It should have information about my prescription plan. Here it's just got letters, but a lot of times, let's look at this one. So this has a name, it's got my ID, it tells me who my dependents are. What kind of plan is this? It's a PPO. How much am I going to pay for an office visit? If I go to a specialist, how am I going to pay? If I go to the emergency room, how much is my deductible? Don't we all wish that we had a $50 deductible? You always want to check and make sure the effective date. We have a group number. We have a BIN, the plan name. So that's all going to be, let's see what's on this one. Look at the deductible on this one. Wowzer. Look at the plan. Individual. We will never meet it on that. All that information is usually going to be on your card. If not, it should be in your plan, but you should all, as a student sitting right there, right now, be able to talk about what your insurance is. You should know all of that information. So that is about health insurance. So again, remember, Chapter 1 and Chapter 2 go together. 36 questions on the test. Make sure that you study, because I've talked about all of the questions that are on the test. Lots of definitions in this first two. Good luck on your test.